Johnson, I'm going to give you a talk on contrast for MRA, an overview and outlook. I do have to disclose I received research support from GE Healthcare. The goal of the talk is to provide a survey of commonly used MRI sequences, compare the methods to identify use cases, and provide future directions for MRI development. In the vascular system, we have many different diseases which we can intervene upon, but they manifest in different ways. To provide better visualization and treatment planning, we really need an MRA that's robust to this specific disease. In order to generate contrast which is robust to specific disease, we need to exploit one of the various contrast mechanisms in MRA. And they are the fact that blood is in a separate compartment filled with homogeneous fluid, where the T1 is relatively constant, which provides an opportunity for contrast using agents, both natively using relaxation. The fact that blood moves into and out of the imaging seed, providing inflow contrast, and the fact that blood is moving relatively fast, providing opportunities for motion contrast. Let's first talk about relaxation contrast. If we look at standard sequences we might use for MRA angiography, we'll find a couple things. First, that spoiled gradient echo sequences provide almost no contrast with tissues such as fat, muscle, and liver, and are not particularly useful in the non-contrast setting for MRA angiography. In the case of imaging where we have balanced SFP imaging, we are able to create contrast between many tissues, such as blood and muscle, blood and liver. However, there are still issues with fat and issues with SAR and banding. This is being alleviated in some way with new advances, such as this example using ultra-short TR balanced SFP from Gregorz-Bellman, where they shorten the TRs to less than 1.4 milliseconds and provide large volume imaging suitable for pulmonary imaging without the band artifacts. Now this is nice, although we do see the fact that we do still have fat signal, which may obscure certain vascular pathologies. We can also, of course, compare this with something like tissue preparation, which is really the subject of coronary and cardiac imaging, which I hope is covered on September 13th, and I hope you joined that. So that leaves us with contrast enhanced MRA, where instead of imaging the sort of native signal, we image the enhanced signal, secondary to an intravenous injection of gadolinium. Now there are two main strategies with this, both using spoiled gradient echo sequences. The single frame acquisition, where we acquire a gradient echo sequence after some time, monitoring the signal and then starting to scan, and dynamic scanning, where we scan contiguously and then retrospectively select the frames of interest, typically using an accelerated acquisition using view sharing. Now, when contrast enhanced MRA came out more than 20 years ago, it really changed the landscape of MRA angiography, providing far superior image quality to techniques such as 2D time of flight in certain vascular observations. In the 20 plus years since then, contrast enhanced MRA has gotten much better. It provides much higher resolution using parallel imaging, provides fewer artifacts using better injection schema, and is also more robust due to better technologist training due to experience, and better tools for timing, such as real-time fluoroscopic triggering, which weren't available initially. I would urge you to sort of go into this more in detail by listening to Colin Primrose's 2 talks in the showcase and also in the joint session 3, talking about some of the artifacts we have in MRA and how to resolve them. What you'll find in those talks and otherwise is that even if you have the best MRA, there are still things that are lacking. So in this case, we do see some vascular structures which are partial filled, so for the hepatic system, which may or may not be of interest. And we do see some partial filling of renal veins, which also may or may not be of interest in this case. And this is a well-timed, high-quality MRA. So the question we may ask ourselves is, are there other options? And one option would be to, instead of using gadolinium, is to use ferromoxetol. Ferromoxetol is an iron supplement with a growing safety profile, with recent multi-center safety studies suggesting that it is safe or relatively safe for off-label diagnostic use. And the key thing that's different with ferromoxetol, it has different kinetics. It has a plasma half-life of roughly 15 hours, meaning it stays intravascular, and we don't need to worry so much about timing necessarily. Due to its structure, shown here, it has a strong T1 and T2 star shortening, which can be used to exploit develop contrast. Now, if we just do comparisons of ferromoxetol to gadolinium, simply using identical protocols using breath-held MRA, you can see it's kind of the image quality you might expect from ferromoxetol. The first pass MRA using gadolinium on the left here, showing nice contrast, nice visualization of structures. An image acquired immediately post the first pass also looks quite good, although there's some reduced contrast between some of the structures, simply due to the contrast dispersion. The paramoxetol scans that you can get are quite similar to that, the post-contrast image, although there are no issues with timing here. And the contrast, in fact, is a little better, in fact, than the post-gadolinium, potentially due to different dosing and different distribution of the agent within some of the non-vascular structures. So some of the cool things you can do with paramoxetol nowadays is you can do things you couldn't do necessarily with gadolinium, such as in this example in some of our studies, where we've compared breath hold imaging to free breathing imaging using a UTE radial sequence with gating. What we found is that free breathing sequences with MRA are possible with improved visualization of non-vascular structures in particular, due to the fact that the resolution and sequences can be much longer than the breath hold scan. Of course, we shouldn't forget the dynamic scan. And how has that progressed in the 20 years? Well, it's become much better. View sharing, though, is still the standard dynamic MRA technique, with basically data shared amongst frames, allowing us dynamic visualization across a range of territories. Likely you'll see this in some detail in sort of the whole body MRA sessions. It does provide lower spatial resolution and different artifacts than you might see in the typical single phase imaging. Now, it still does require a lot of patient training or patient coordination and training with the radiographers, particularly when trying to coordinate with a breath hold, where we have to have the entire scan within 10 to 20 seconds of imaging, which can limit the kinetics we can visualize, but also limit the spatial resolution we can achieve. Ideally, we'd be doing ungated contrast MRA, where instead of doing a breath hold, we simply let the patient breathe, inject, and image everything in retrospective. This would be a lot easier. We would have no timing issues, no breath hold issues. The issue there has always been that you need really high acceleration rates, and you can't use view sharing, which doesn't work very well with respiration due to the moving vascular and non-vascular structures. However, there's been a lot of progress in this area in dynamic contrast enhanced imaging, for example, with XD grasp techniques. One particularly promising technique is a technique proposed by Frank Ong, which is called extreme MRI, which is a technique using extreme temporal resolutions using a low rank reconstruction. Here's just an example here in a pediatric case, acquired at relatively relatively coarse resolution for a dynamic contrast enhanced scan. However, we can see a nice visualization of all the vascular structures and the filling of the structures during respiration, instead of trying to resolve them independently. This is definitely an area for development. However, it recognizes the fact that DCE and MRI are perhaps converging on some kind of solution, and perhaps we should be considering confusing dynamic contrast enhanced imaging and MRA imaging. What if I can't give contrast? Well, one option is to use inflow. Inflow is well described in many techniques, such as time of flight, where as we have fresh blood coming into the volume, here divided by 1, 2, and 3 every time you see an excitation, it sees fewer excitations than it would if it had been in the volume the entire time. And hence the signal is much higher than it would be otherwise, providing contrast between the background. Now, recently, in the past probably decade, we've had a lot of advancement with Inflow Prepared MRA, either with or without subtraction. So, for example, in the subtraction techniques, we will apply a preparation module that's inferior to our volume, allow blood to flow into the imaging volume, and then subtract an acquisition with and without this 180-degree prep to provide contrast based on the inflow time. Just to show you an example of this in a brain example, here showing the visualization of the draining veins of an AVM, shown here with 3D time of flight and the feeding arteries as well, showing this banding artifact we get from inflow saturation, where we don't get those with the inflow prepared techniques, which sort of decouple the imaging and inflow preparation, and much better correspondence with DSA. We can also do this in the body, although subtraction-based MRA is fairly challenging, and non-subtraction is generally used, where we may apply something like a preparation, such as an inversion, allow that preparation to be infilled with fresh blood, and then do imaging after we've had the full volume filled up with bright blood. This allows us to sort of null the signal from background. Here, the kidney here sees the 180-degree pulse, some recovery, and is basically nulled at the imaging time. But since blood is not in the imaging volume when the 180-degree pulse is applied, we get much higher signal. Now this can enhance spins at a cost though. So here we see better visualization of the renal vasculature compared to an unprepared sequence. Although you do see we lose some of the structures you get in some of the the background in the liver here due to the fact that it's now flow sensitive. So this technique is highly useful for renal imaging in the peripheral vasculature and definitely becoming much more reliable with techniques such as KISS. Finally, I'd just like to briefly touch on motion encoding. Now there are 2 great talks and sessions that are coming up, or 4 talks and 2 sessions that are coming up on the 12th, both with 4D flow and carotid wall imaging, which we'll see in more detail. But I should say that there are techniques in angiography here, not just for the quantitation and vessel wall characterization. So for example, we can do PC-MRAs, where we take the magnitude and velocity and create an angiogram. And this creates angiograms which are quite nice these days. They have progressed a lot since with some of the initial comparisons with 3D time of flight. Here showing an AVM example, comparing near equivalent performance between inflow preparation 4D flow scan and post-contrast MRA scan. We can also do this with black bud imaging using a different technique in which we take a black bud technique and a bright bud sequence and subtract the two to create a subtraction angiogram, which is definitely a technique to provide much better visualization of slow flow. Here another comparison of that showing the motion prepared sequence on the left for slow flow and the typical inflow prepared sequence on the right for more arterial flow. This is in a still case showing the black bud imaging showing much better visualization of slow flow than an inflow 3D time of flight sequence. All right, with that I'd just like to summarize that there are a lot of mechanisms which you can use to generate contrast, MRA contrast, being agents, which is something that excels below the neck, inflow, which provides fast flow imaging, and motion, which can sort of be tailored a bit depending on your application, with fast flow using 4D flow techniques and slow flow using black bud techniques. With that, I'd just like to thank the whole SMRA team for throwing this virtual meeting together and many of the contributors to these slides. Thanks.